Hi, everybody. Good morning. My name is Kimberly Bruce, and I'm the marketing coordinator at Montrium. And we are ecstatic to have you here for day 2 of TMF week. But before we actually get started, we need to go through a couple of ground rules before we get to our session, our first session of the day, which is bridging the ISF TMF divide. What roles should sponsors and investigators play? So just so that you know, this isn't session where you can ask questions at any time. We will be fielding the questions and your questions will be answered at the end of the presentation. All sessions will be recorded and available following the event on the event platform, and all attendees will be receiving certificate of attendance for the entire week. So that should be happening 7 days after the event has ended. And also feel free to check out the lounge area so that you can interact with your peers, colleagues, and don't forget to check out the virtual platforms and the virtual exhibitor booths so that you can meet with the companies that are powering TMF Week. So today's speaker is Thomas Cocciardi. He's a technical writer at MLK Clinical Research Consulting. And Thomas Cocciardi is committed to expressing the human story behind each TMF. He also works as a medical writer. Cocciardi has gained wide-ranging experience both in and out the pharmaceutical industry as a regulatory writer, TMF-focused clinical trial associate, TMF health specialist, and clinical research coordinator. He holds an MS in regulatory affairs from Northeastern University and the RAC US credentials. So without further ado, I would love to pass the mic over to Thomas so that he can wow you. And remember, ask as many questions you want. It is encouraged. We will get to them at the end of the session. Over to you.
All right, thanks. Let me share my presentation here. We'll get started.
Excellent. Perfect.
That look good?
That looks perfect.
All right, fantastic. All right, thank you for the warm introduction, Kimberly. It's great to be with all of you today, and good morning or afternoon, depending on where you are in the world. In today's presentation, we're going to reflect on why we have both the sponsor TMF and site TMF and the challenges we face in maintaining them in parallel. In doing so, we'll discuss how the regulatory roles of sponsor and investigator shape the TMF. We'll face down some site-specific TMF compliance challenges. We'll examine the possibility of eTMF and eISF integration, and we'll consider how the right kind of ISF reference model could benefit sites and industry as a whole. So let's get started with your participation. We know standalone eTMF adoption is approaching 80% in the clinical operations community, especially for CROs and sponsors. We often talk about eTMF adoption and digital transformation in the sponsor TMF, but when we celebrate the success of eTMF adoption, we rarely consider sites. Since today's talk is going to focus on regulatory documentation at the site level, it would be helpful for me to understand your experience with sites' regulatory documents. So if you could, I'd like your estimate of the percentage of clinical trial sites you work with that are still using mostly paper regulatory documents. And I'll give you a few moments to answer. All right, let's see what we have here. All right. So I think that's mostly what we're going to see. All right. Thank you, everyone, for your responses. So as we can see, the majority of sites still work with paper documents, even though the CROs and sponsors these sites work with do not. So of course, this mismatch presents many challenges and regulatory risks to all involved in a clinical trial. It also limits the benefits of sponsor and CRO eTMF adoption. But before we discuss what to do with the risks associated with sites' paper regulatory documents, let's take a step back and consider what we're striving for in the first place, and that's a complete and healthy TMF. We often just think of the TMF as the sponsor's documents. Even when we talk about site-produced documents, we think of them as a work product for delivery to the sponsor TMF, and we don't really think of the site of having ownership of those documents. However, this industry preconception of the TMF simply isn't regulatory reality. I have here 2 quotes from GCP and EMA guidelines that specifically state there are 2 TMFs. There's the trial master file at the site and the trial master file that belongs to the sponsor. That means a TMF is only complete when the investigator TMF and sponsor TMF are considered together and found compliant. In fact, the investigator TMF is so minimized, we refer to the sponsor TMF as just TMF, and we don't have a consistent word for the site's TMF. Sites call their documents a regulatory binder, reg docs, or site docs, and because of this, I want to clarify some terms. For the remainder of this presentation, I'll refer to the sponsor TMF as eTMF and the site TMF as the ISF, or maybe EISF if I'm talking specifically about an electronic investigator site file. Most of us have experienced the relationship between eTMF and ISF as troubled. On the sponsor CRO side, we've successfully eliminated paper documents because we know we can't achieve regulators' expectations with the legacy paper TMF. But as we discovered through our last poll, paper documentation still reigns supreme at the site. This means the ISF is a huge uncontrolled risk for the sponsor and a magnet for inspection findings that reflect negatively on everyone, including the sites. MHRA's most recent GCP inspection metrics tell the tale. Record keeping as a category continues to produce inspection findings despite CROs and sponsors' eTMF adoption. In fact, record keeping findings were the #1 most common category for sponsors and the 2nd most common inspection finding for CROs and investigator sites, according to those MHRA GCP inspection metrics. Of the small number of findings MHRA chose to summarize, 2 involved problems potentially related to poor TMF-ISF integration. The first critical finding mentions an incomplete and inaccurate TMF that was strewn about multiple locations and depended on Excel to organize the documents. The second finding discusses the existence of a shadow TMF on a coordinator's computer, even though MHRA was inspecting a supposedly fully paper TMF. In general, it's my opinion that these findings would have been prevented if both CRO and site used a purpose-built electronic document management system. FDA BMO inspection metrics for the last 2 fiscal years show the same pattern. Inadequate records were listed as a common inspection observation for the past 2 years. These inspection findings confirm an uncomfortable truth. The fact of the matter is, even if a sponsor or CRO has a great eTMF system, supportive TMF culture, and well-thought-out processes, a TMF cannot be compliant if all the ISFs within are unhealthy. This is because documents flow from the site to the sponsor, so the sponsor needs to come up with a solution to deal with site's paper regulatory documents, and because the sponsor only has so much visibility into each site's ISF. This begs the question, why do we have this division between eTMF and ISF, especially if it creates so much extra work and regulatory risk? I'm sure sponsors and CROs would love to take the site's documents in-house and fully incorporate every single clinical trial document into one unified platform. It would be so much easier to deal with only one centralized document repository. Well, there are 2 reasons why the eTMF and ISF remain separate to this day. The first is that the trial master file must reflect the roles of sponsor and investigator to fulfill its purpose, which we know is to permit regulators to evaluate the conduct of the study and the data produced. And the second, and perhaps most important reason for this division, is because GCP and most regulatory bodies tell us that they must remain separate. The following text is taken directly from CFR. It's the main section that outlines the roles and responsibilities of the sponsor. As we can see here, sponsors pick investigators, they train those investigators, they assign monitors to ensure protocol compliance, they manage safety reporting, and they maintain the IND. From this definition, we see that FDA has directed the sponsor's energy towards oversight and completing the high-level regulatory requirements of moving an investigational product towards marketing. Of course, the sponsor's roles and responsibilities are different from the roles and responsibilities of the investigator, so let's take a look at those. According to CFR, investigators execute the protocol, they protect patients' rights, and they dispense investigational product. Through this regulation, FDA has directed the investigator's energy towards protecting patient safety, maintaining informed consent, and carrying out the real-world completion of the trial. The way in which the regulatory roles of sponsor and investigator are oriented produces a system of checks and balances that make sure business motivations don't overtake ethical research considerations. For example, while the sponsor may more heavily value efficiency and timeliness, the investigator ensures efficiency and timeliness do not compromise patient safety. Or, while the investigator may occasionally stray from the protocol, the sponsor is able to provide oversight to return the investigator to compliance. The sponsor and investigator, therefore, need their own separate TMFs because the role of sponsor and investigator have independent, although complementary, role-based goals. I should also note that while CFR is US-centric, ICH-GCP is extremely similar in its requirements. So the investigator-sponsor relationship is structured in the same way across the globe. As I stated, regulators directly mandate that there are two TMFs and that they must remain separate. The following quotes are from an EMA reflection paper, MHRA forum posting, and the most recent revisions to ICH-GCP. EMA states that the investigator should retain control of the documentation contained in the investigator TMF, and the investigator TMF should never be sent to the sponsor organization. MHRA says, in most cases, it is essential to segregate those documents that are generated or held by the sponsor of the trial from those of the investigator. ICH-GCP E6R2 adds an addendum in Section 8 that says the sponsor should ensure that the investigator has control of and continuous access to the CRF data reported to the sponsor. The sponsor should not have exclusive control of those data. In all cases, these regulatory bodies are clear that segregating the investigator and sponsor's documents is essential, and generally they cite the same imperatives: patient privacy and investigator autonomy. To understand the rationale behind this separation on a deeper level, it's also helpful to consider the documents that are found only in the ISF and not in the TMF. These are identification lists and informed consent forms, case report forms, and source documents. Those who have worked with clinical documentation for any length of time know the burden and responsibility that comes with the possession of personal health information, or PHI. Permission from subjects is required for the collection of PHI, and PHI can only be collected for reasons critical to the compliant conduct of the trial. Because of the gravity of PHI, it isn't in the sponsor or CRO's best interest to collect it if any reasonable alternative exists. Because once we have PHI in the TMF or anywhere, our trial processes and documentation need to comply with HIPAA legislation in the US, GDPR in the EU, and potentially dozens of other regional privacy regulations. We combat this risk by anonymizing subjects in the TMF, by ensuring documents that link subject numbers to a subject's identity, like identification lists or perhaps consent forms, remain close to the subject at the trial site. But this doesn't explain why CRFs are also only found in the ISF. CRFs and other source documents stay at the site because they fall into a special regulatory category. Source documents and CRFs are the primary source of the trial's data, so they need to be treated with special care to ensure accuracy and to protect the quality of the data. In other words, the primary source data reflects the ultimate clinical judgment of the investigator. MHRA makes it clear that the investigator's independent control over these documents is essential to ensure the investigator is free to exercise their clinical judgment without undue influence from the sponsor. So now that we've established that we are stuck with two TMFs and that this arrangement produces a lot of regulatory risk, Let's talk about where this risk comes from and what we can do about it. The main source of risk caused by TMF and ISF disharmony stems from the necessity of the TMF and ISF to create a unified narrative despite being separate repositories. As we discussed, the sponsor and investigator have discrete TMFs because of their distinct responsibilities, goals, and priorities. Beyond this challenging difference in motivation, at the present, the TMF and ISF speak different languages. The language of the TMF is the structure of the reference model that the clinical operations community has decided to adopt. As we discussed, and you all know, the reference model is a taxonomy of documents that assigns every TMF document a zone, section, and artifact. And this enables consistent filing across a study, between studies, and even between organizations. ISFs, however, have no standard language, and most ISFs are unique to each trial site and can vary significantly between protocols even at the same trial site. Because the TMF and ISF speak different languages, we run into several common ISF-TMF harmonization problems. The most common and concerning is the lack of completeness in both the TMF and ISF, because without a one-to-one correlation between the zones of the reference model and components of the ISF, it can be difficult to determine what documents must be collected and when. It can also be difficult to determine whether the documents are supposed to be filed in the ISF, TMF, both locations, or not filed at all. Another common problem is the lack of contemporaneousness. Without great communication with the trial site, the sponsor must depend on document collection during infrequent monitoring visits. Delays between collection and filing in the TMF often allow more serious issues to compound. One such issue that compounds over time is document duplication. Lack of contemporaneous filing and the physical separation between the ISF and TMF create the ideal condition for duplicates to proliferate. In addition to lack of completeness, contemporaneousness, and the other issues we discussed, the need to convert paper documents to digital documents often threatens document quality. And finally, resolving document quality issues takes a huge amount of time, strains the site-sponsor relationship, and further intensifies the risk of other errors occurring, including version control issues that lead to more severe inspection findings. It happens because keeping version documents in sync across dozens of sites, especially when ISFs are unhealthy, can prove impossible when no one can use the information in the ISF as a prospective trial management tool. It's hard for me not to see these problems and immediately draw parallels to the many challenges CROs and sponsors overcame with eTMF adoption. I can't help but ask, would the same approach we use to transition from paper TMF to eTMF work for sites? Frustratingly, I don't think it's that simple. Sites would have adopted eTMF technology by now if it met their needs, and they haven't. And they probably haven't adopted eTMF technology because there are some key roadblocks to EISF adoption that no one's addressed. One of the first roadblocks is metadata. Metadata is simply non-content document information. The example I like to give that's most simple is a file name, but there are lots of other attributes and metadata a document can have, like trial number, language, signature status. And paper documents don't really have digital metadata in the traditional sense, which means that documents cannot be digitized from paper without massive manual intervention. The next roadblock to EISF adoption is related to the technology that supports an EISF. Even if a site wants to adopt an EISF system that doesn't require on-site hardware, like something in the cloud, the site may not have the basic document handling technology, like a stable internet connection or scanner, necessary to efficiently utilize that system. An EISF system requires new skills and expertise, so to implement an EISF system, a site staff will require training, and the site's SOPs and workflows will require updating. This also takes significant resources that might not be available to a site. Of course, the EISF system will require significantly more consideration of security compared to physical documents, and a site might feel that the transition is not worth the risk, especially if that site doesn't produce a high volume of regulatory documents in the first place. Overall, it took sponsors and CROs more than a decade to navigate the eTMF digital transformation, and many aspects of that are still underway. In comparison, today's trial sites have far fewer resources to complete the same journey and much less to gain from adoption. All these barriers, though, are small compared to factors of commercial viability. Sites won't seek out change without a concrete answer to this question. Who's going to pay to fix the ISF problem, and does the effort make any economic sense? So let's take a break to acknowledge that some progress has been made in the past few years towards the creation of site-focused EISF solutions. Some are more comprehensive, while others seek to recreate the reg binder in digital form. Right now, there are some early adopters that are using EISF technology with great success. They are, however, usually large academic or network sites that have deeper pockets. So if you could, I'd like your estimate of the percentage of clinical trial sites you work with that have a purpose-built EISF system, and I'll give you a few moments to answer. Interesting. So your responses reflect my expectations. In general, we can see there's a small collection of sites, generally potentially the larger ones, that have adopted EISF technology, but the limited adoption overall reflects the high number of sites that still use paper documents. So regardless of the challenges we discussed, I think we can all agree trial sites need a solution for paper regulatory documents, or the trend of inspection findings is only going to magnify. So now, how can we generate some positive momentum towards TMF and ISF harmony? In this case, I think it's helpful to take a cue from the sponsor and CRO's TMF migration journey. Their first step towards eliminating paper was to create a reference model. Their adoption of a reference model produced TMFs that were finally compatible with digital document technology without so much manual intervention. In fact, some of you might ask why we can't just use this existing reference model for sites. To this, I would say right now, in the huge comprehensive reference model, sites are relegated to column N. To me, this seems like an afterthought. The TMF reference model was built to aid the implementation of eTMF technology and ultimately achieve the goals of the sponsor and CRO. It doesn't really address the needs of sites. Because of this, I see two reasons why the TMF reference model and other prior attempts at ISF standardization have not really caught on. The first is the status quo checklist mindset. Most sites have their own regulatory document checklists of paper documents that should be filed in a site's paper regulatory binder have existed for decades. In my opinion, though, expected document checklists, although greatly useful, distract stakeholders from thinking critically about what their regulatory binder needs. And it also prevents them from really thinking about study-specific circumstances unique to a protocol. Column N in the reference model functions a lot like a checklist, and we can see a photo of it here. Column N essentially extends down for every artifact, saying whether no, it's not expected as an investigator document in the ISF, or it just has an X saying it is. But the second and most consistent reason I believe sites have not adopted the reference model is because most proposed reference models were created by sponsors or CROs. These sponsor or CRO focused reference models were designed to make things easier for the sponsor and not for the sites. And sites simply had no reason to keep using them once they stopped working with the sponsor. So these past unsuccessful attempts at bringing consistency to the ISF suggest we'd be wise to start from scratch and design a purpose-built ISF reference model that puts the needs of sites first. This ideal ISF reference model would work for both paper and electronic ISFs, but make the long-term evolution to eISF easier for sites. It should and could provide short-term benefits of increased efficiency and completeness in its standalone implementation without huge financial commitment. A site-focused ISF reference model would provide more granularity for artifacts that sites care about and eliminate the bulk associated with documents sites rarely or never work with. A site-focused ISF reference model would give sites access to benefits previously reserved to sponsors, especially the ability to move towards automatic generation of performance metrics and other automation overall. Regardless of the details, any successful site-focused reference model must provide sites with a short-term why and an attainable long-term vision for the future. Of course, we can't talk about the replacement of paper regulatory documents with electronic ones without addressing the impact of COVID. During COVID, sites were forced to use electronic documents because they simply couldn't get to their paper documents at the site. And while the full impact of COVID on clinical trial sites is well beyond the scope of this presentation, it's worth mentioning that short-term efforts to digitize trial site regulatory documents were probably not sustainable and may not have even been compliant. COVID definitely gave sites another reason to adopt eISF technology and shifted some cultural expectations, especially ideas about what can be done remotely. But most pre-COVID challenges to eISF adoption are still relevant. So we need to give sites better solutions or they'll revert to paper as soon as they can. Now I have one final survey question to end this presentation. I want to know whether you believe the benefits of digital documentation technologies have been equitably distributed between the roles of site, sponsor, and CRO. I know this question is a little bit loaded, but it's worth asking. So let me give you a few moments to answer.
And hi, everybody. I'm back. I just wanted to let you know on the top right corner is where the poll is actually being submitted. So if you guys will go up there and just select your answer, that would be most appreciated.
Thanks. All right, so the responses are coming in and we can see it kind of was a loaded question. So if you agreed with this statement, I believe you have an excellent working culture that upholds a healthy relationship between site, sponsor, and CRO. And this is like the regulation intends, but it's rare. We have a lot to learn from you, and I hope my presentation inspires you to speak out about how you're fostering these healthy relationships. If you disagreed with this statement, I understand why. The TMF tells the story of a clinical trial, and the documents within reflect our attitudes, belief, and choices about the work we do. I made this presentation because I'm not sure we've done everything we can to empower investigators and to make sure the ISF is part of the better future we've built with eTMF adoption. But no matter your response, I want to confirm I don't have an easy answer to bridging the gap between eTMF and ISF. In fact, now we all know this gap is partially intentional. I do know, however, the balance of the eTMF, restoring balance between the eTMF and ISF will require restoring balance between the roles of sponsor and investigator. For the past decade, sponsor eTMF technology has taken center stage. We know the sponsor has nearly limitless resources compared to the trial site. This isn't equitable, and it minimizes the role of the investigator, which puts ethical research at risk. To see a true digital transformation at sites, sites have to be part of the ongoing process of modernizing the TMF. They have to be represented at the table. They have to want to use the technology, and they need to reap rewards consonant with their efforts. Any eISF solution must protect investigator autonomy and support a healthy and compliant relationship between site and sponsor. Only then will the sponsor and investigator relationship flourish and potentially some harmony be restored between eTMF and ISF. So on behalf of LMK Clinical Research Consulting and the folks at Montreal holding TMF Week, I want to thank you for your attention, participation, and your questions. I'm happy we could discuss these ideas together. And I think we have a few moments to answer some of your questions now.
Great stuff. Thank you so much, Thomas. So now we're going to actually get into the question portion. And here's a question for you, Thomas. Somebody had asked, can you explain duplicate documenting and what that represents?
So duplicate documents, they're just kind of what they sound like. Earlier on in my career, when I was kind of as part of a SWAT team to fix broken TMFs, one of the hardest, most initial challenges of dealing with a dysfunctional TMF was just the sheer amount of duplicate documents. So these are like 4, 5, 6 copies of the same thing filed in the TMF, and it's just frustrating because they don't need to be there in the first place. And if you are trying to measure TMF health, you need to get rid of them. And in my opinion, a lot of those duplicate documents come from different people at different times encountering the same document and filing them without being able to see what's already there and without being able to access the information in the TMF. And I think the worst part about duplicates is the more of them you have, the more time it takes to check for duplicates, and the more of them you'll end up with. So you can really have this snowball effect. And so I think solving the problem of duplicates really comes from making sure they're not there in the first place and reducing the time from document creation to filing as short as possible.
Excellent. And I'm going to ask you, Thomas, if you can just turn on and turn off your camera. There seems to be a little bit of a glitch, so it should be able to fix the problem that's there, and then you can turn it back on.
And my back.
Okay, perfect.
Awesome.
Excellent. So thank you very much for that answer. And we have another question here. What do you think the recent pandemic offers in the way of decentralizing the ISF softball to suggest the sponsor support and electric reg binders? Sponsors need to stop the seagull. So like what would you think, what do you think about that?
So I think we should be cautious and not celebrate that, oh, the sites are sending me digital documents now, so now we have an EISF. My guess is that the sites were absolutely killing themselves to send you those electronic documents, and they were working late in front of a scanner and pulling their hair out getting them to you. But I do think what COVID did is make sites realize that they don't want this to happen to them again. And so they have a reason to adopt EISF technology. So they'll probably be more open to any solutions offered to them. And they might just give their sponsor or CRO, a free pass to suggest one more electronic system when before that's the last thing they'd want to hear about.
Okay, great. Thank you very much. And next question is, if the sponsor and investigator should have different TMFs, what about a sponsor investigator?
So a sponsor investigator, I believe there are separate categories for sponsor investigators where this division would not apply so specifically. I would just caution anyone working with the sponsor investigator situation to understand how that will impact their TMF, and definitely realize that maybe if you've had the more traditional sponsor CRO site relationship, that what you did before probably won't work specifically in this situation.
Okay, excellent. So next question was, we often boil down GCP for sponsor and site to participant safety, protocol followed, participant data excellence. Do you think this is sufficient to capture what the records need to detail?
So this kind of refers or just reminds me of the checklist mindset I was talking about. I don't think anyone should ever be sure that what what list they have is complete, whether it's the sponsor TMF or the site's TMF. There will be site and protocol specific documents that you need to maintain in addition to what you thought you needed. The best, most healthy TMFs, people are continually thinking about the story in that repository, and they're adjusting as they go to make sure they're capturing everything that's going on.
Mhm.
And GCP and really all these regulations and guidance aren't written to be a panacea. They're just inviting you to think about the right things.
Okay, perfect. So I have a next question here. How can sponsors and vendors best support the sites in the journey to unify the site file name? What do sites want?
So I think sites mostly want you to realize that they are different from you. They aren't a vendor, they aren't a CRO. They want you to think about their point of view. So think about working at a trial site with 5 staff. Think about how that site needs much lighter solutions. Think about how they're dealing with 20 different sponsors. Maybe that's a high number. And just think about the simplicity that they need and the fact that their role is different than yours. And their role is supposed to be equal to yours. And that's important to having ethical research. So just think about how you can support them and what they need to do, not how you can force them to do what you need them to do.
That's a very good point. We have another question here. Who pays for the software upkeep of documents? Can this be added into a trial budget or something similar?
So negotiating budgets is a little outside of my wheelhouse, but I would say that's clearly you're thinking that somebody has to pay for it. I've seen some free solutions out there, at least they're free right now, that look really great. I think there's also a situation where the investigator could potentially make the sponsor pay for their own system, or at least charge them for storage or some kind of fee. I do think there is a situation where maybe the sponsor could pay for it and have their own system that they could provide access to, especially if a few providers become kind of the industry leaders. But I would caution that anytime you have a sponsor with their own system that they're imposing on the site, you're going to jeopardize the site's autonomy. So either this needs to be free, or we need to come up with some way for the investigator to be paid to maintain a system that they want to use and that they can use with every sponsor.
Okay, perfect. So thank you very much, Thomas. This was a very, very engaging presentation and engaging session. Thank you to the attendees for asking such great questions. Whenever we can, we will try and get in touch with you if ever there are any other questions that you would like answered. Up next, and I would just ask you, Thomas, to stop sharing your screen. I just want to put up, no problem. Thank you. So we are on the question portion, which is done. So we just wanted to say now is going to be the break, so you guys can go to the lounge area so that you can interact with attendees and also check out the virtual booth. And up next will be the foundation of the clinical trial story. Starts with study startup, and that will be with Jennifer Wilson and Elvin Tilland coming up at 10 a.m. So just want to say thank you all for participating in this session. Thank you, Thomas. You were awesome, great, loved it. And you answered a lot of very poignant questions. So until next time, enjoy the conference, and we'll see you again soon.
Thanks again.
Bye for now. Thank you.
Bye.
Bye.